Hello, everybody. Welcome back to the Doc Talk podcast. I'm Dr. Shazma Mathani.
And I'm Dr. Sheila Wijaya Singha.
And a special thank you to our episode sponsor, Figs. So obviously in our line of work, you kind of live in your scrubs. And if you follow us on Instagram, you probably already know this. We are obsessed with Figs. They're super comfortable, breathable, durable, and they actually fit, which is a huge upgrade from those horrible itchy scrubs that were status quo for so long. They're also just super cute and stylish, and you just feel good wearing them.
Yeah, like you said, Shaz, we're obsessed with them. But you know what I love most about Figs is that they just get what it's like to work in this field. It's not just that they know what we need, like 7 pants pockets to carry our stuff around. They've also built this incredibly supportive community of people who work in healthcare and who want to have important discussions to make real connections with others who work in the same fields. So I've been to a couple of events, Shaz, as I know you have too, and it's really refreshing for a brand to show up in such a real way. And if you're not following them on social media, guys, their memes are great. If you work in healthcare or know someone who does, Figs is it. And right now, if you go to wearfigs.com and use code FIGSCA, that's FIGSCA, you can get 20% off your first order. That's wearfigs.com, code FIGSCA.
So today's episode is one we've been thinking about for a really long time. But if we're being honest, it's also one that feels especially urgent right now, which is why we wanted to prioritize it.
So over the past few weeks, Shaz, you and I have been talking about this quite a bit, and we know many of our colleagues and the public have been shaken by the tragic death in a hospital waiting room. At the same time, a number of people across the country are living right now without a family doctor and are trying to navigate a system that feels confusing, fragmented, and increasingly hard to access.
And this is really part of why Sheila and I do this podcast, why we write in the Globe and Mail, and why we show up on social media, because we know that access to care is not equal. And when access is limited, information becomes even more important to share.
So one of the big things too, Shaz, you shouldn't have to be an insider to understand where to go for help and understand what the emergency department can do or can't do and what options exist for you if you don't have a regular family doctor or a primary care clinician. And this is why we want to talk about it.
Yeah, absolutely. So today we're taking a step back and walking through how the Canadian healthcare system is actually set up, what each part is designed to do, where it often breaks down, and how you can navigate it safely and effectively, as well as advocate for yourself as you're doing that.
Great. So let's talk about how our system is structured to start off, Shaz. I think it's really important for everyone to understand that, our healthcare system is publicly funded by our federal government, but it's provincially run. And so that means that the rules, the access points, and wait times do vary depending on where you live.
Yeah, and I think that's a really important point because, like you said, the funding comes from the federal government, but that's then distributed to provinces and they decide kind of where to put the money, how the system is run. And oftentimes when people hear universal health care, they often think that means easy or timely access to care, when unfortunately right now in reality, that means medically necessary care is publicly funded and you do have access to it, but it's not always instantly available.
Yeah, so the biggest barrier for Canadians right now isn't that they're not covered by our provincial health plans, it's just the access to care.
And I think a big part of that access right now is that our system is built around the idea of primary care as a central hub, which is important and actually I think is the way that it should be. The problem right now is that we don't have a lot of family doctors. These family doctors are meant to coordinate care, to manage chronic illnesses, order tests, make referrals, and kind of be that central hub for a patient and get them through the healthcare system. But, as we've talked about before, there are millions, up to 7 million Canadians who don't have access to a family doctor right now.
Yeah, and I am a family doctor working in this system right now, Shaz, and we talk about this a lot. I understand the benefit of having a family doctor is huge because we are the quarterback to the healthcare system. We are the ones that are going to get you to the care that you need. We will advocate for you to get that care, hopefully in a timely manner, and are your safe space really to be able to discuss these concerns that you have. And so many people don't have that. And it becomes so hard to navigate without a family doc.
Yeah, and I want to talk to you a bit more about the role of family doctors in the system because a family doctor is not just someone you see when you're sick.
Yeah, exactly. And you mentioned this before, a lot of the work that I do as a family doctor is around prevention. So I'm making sure that you're up to date for your screening for specific cancers. I'm checking your blood pressure, your cholesterol, your blood sugar, so we can manage your heart disease risk factors. And we're also managing chronic conditions like diabetes or high blood pressure to make sure that you're not ending up in the emergency room to see you, Shaz, because those conditions are not managed.
Yeah, and it's so not only all of those important things, like those foundational things, Family doctors are always also the gateway to specialist care. So they order outpatient tests, they interpret results, and then decide when specialist referrals are needed. So for example, I mean, like if there's something that is unusual from like a cardiac standpoint, you might refer someone to a cardiologist. If someone needs to have a knee replacement and it's not being well managed with the conservative care and the foundational care that you're providing as a family doctor, that's when you might refer them to an orthopedic surgeon. And so the family doctor is also that kind of like hub to the specialist too.
Yeah, there's a lot of different things that we do as your family doctor. And also equally important is after you leave the hospital or after you see the specialist, often my patients will come in and be like, I just want to review what they said to me, Dr. Sheila. I wasn't quite clear on what they said. I make sure that after you've left the hospital that all your discharge medications are organized properly and you're making sure that you're getting those medications in a proper way. And so we're really connecting the dots for you of the different healthcare system in a very meaningful way so that you're not struggling through the system.
And then the problem with that is that when people don't have a family doctor, that continuity disappears, right? And so patients are often forced to either piece together care with walk-in clinics, virtual visits, and emergency departments.
So what do you do if you don't have a family doctor, which again, like you said, Shaz, is up to 7 million Canadians right now who do not have a family doctor. And that is not a personal failure. It's a systemic issue right now that we're trying to remedy and come up with solutions. But in this moment, what do you do if you don't have a family doctor?
Yeah, and I think, I mean, like you said, this is affecting millions of Canadians, so it's important to know what the options are. These can include things like walk-in clinics. There are some virtual care platforms. There are nurse practitioner clinics as well, community health centers, depending on where you live. And there are urgent cares as well, depending on how acute the issue is too. And then, of course, emergency departments if needed.
Yeah, exactly. Like you said, so these services can be helpful for those acute issues, prescription renewals and basic assessments, but they may not have the continuity piece that we really need as human beings so that we have all our care needs met as well. And you may not see the same provider twice. They may not have access to your full medical history, and follow-up can be inconsistent. And this is where sometimes my patients, I understand that if we're not available, they'll go to a walk-in clinic, but they're given something that actually is not compatible with their health. And we always try to emphasize, come and see us. We have after-hours clinics, making sure if you do have a family doctor, check in to see what other options are available within your own clinic as well. Because again, we have 7-day access at our clinic because we are responsible for our patients every day of the week, 365 days of the year. And I know that's not the case everywhere, but please always check in with your own doctor because often my patients didn't realize that and they end up going to a walk-in clinic and then they miss that sort of continuity piece.
Yeah, absolutely. I want to shift and let's talk about the role of the emergency department because this is where a lot of confusion and frustration lives. People often come in to see me with various expectations because of just not kind of knowing or understanding how the system works.
And this is, the ER, and what I emphasize to my patients, Shaz, all the time, if I'm sending them into the ER, it's really designed to assess and treat acute, potentially life-threatening conditions. It is not made for primary care or long-term follow-up.
And one of the common misconceptions that patients often come to the emerge with is that they think that they could get access faster, which unfortunately and appropriately is not the case. So like you said, and what I often explain to my patients is that our job in the ER is to rule out and manage potentially life-threatening things. We won't always have the answer to what's going on. And then that's where that community follow-up and primary care follow-up is helpful. People don't come to the emerge because they want to. They come because they're scared, they're in pain, and they're out of options. But I also think it's important to understand that we don't have any easier access to referrals or specialist care compared to the community.
A big thing that we've talked about also, Shaz, and I know this is happening right now across the country, is overcrowding that happens when people who need admission are in the emergency room and because they can't move into inpatient beds within the actual hospital itself. And then that also creates more crowding in the emergency room as well.
Yeah, and I mean, like that often becomes challenging at different times. Right now, we're like right in the thick of influenza season, so we are seeing significant overcrowding. And that's just unfortunately the reality of emergency departments right now. We're stretched thin, we're short-staffed, and unfortunately that translates to wait times that can be long, even for sick people, which I mean, for me as someone who works in the ER is always weighing on my brain. You and I have talked about this before. Like I'm always kind of trying to be aware of what's in the waiting room and always thinking like, I don't want something bad to happen because this is, I mean, this recent case is not the first time that we've had a death in a Canadian waiting room, unfortunately. And my worry is always that this is not going to be the last time.
Yeah. Can you tell us a little bit? One of the questions that comes up often when patients are like, I was waiting a long time, then somebody else went in front of me. Can you talk to us a little bit about how triaging or prioritizing patients works in the emergency room?
Yeah, let's do a little teaching corner on this,
Yeah.
because it is a really misunderstood part of emergency care. And so what happens when you arrive to the ER, the first person that you see is going to be the triage nurse. So they will get a quick story, ask you some questions about what the main reason you're into the ER is for, and then do your vital signs. And so that is what assigns you a triage score. So this triage score, it's the Canadian Triage and Assessment Score, or CTAS. And that ranges from 1, which is like immediately life-threatening, like someone with a cardiac arrest or someone who is actively trying to die, to 5, which is the least acute. So someone with like a sprained ankle or a prescription renewal or something like that, right? And so there is a broad range. And the things that kind of populate that triage score, it's all kind of algorithmic and automatic, is the vital signs and your chief complaint. And so that is really what guides how urgent certain things are, and what the priority of people coming in through the emerge is. So someone obviously that it has concerns for, like a stroke, would come in way faster than someone who is waiting for a prescription renewal or has an ankle sprain.
This is really important, Shaz, because I find patients are confused at this because, again, if they're seeing other people that arrive later, go ahead of them. So I appreciate you clarifying that, because it does mean that sometimes people who arrive later may be seen sooner if their triage score is higher or lower.
Exactly. Yeah, more serious. And so,
More
I mean,
serious.
what I want to reiterate is, like, it does not mean that you're being ignored. It means that at that moment, your condition appears to be stable compared to other people that are in the waiting room as well.
And that being said, conditions can change. So if symptoms are worsening while you are waiting, it is really important to let people know, the triage nurse, the staff, because they can change your score.
And I'm glad that you brought that point up, because even triaging is just like assessing in a moment of time, right? So like what your vital signs are in that moment and what the triage nurse is gathering you from in that moment. And that's when that score is assigned to you. And things can change and evolve, especially with growing wait times. And so if there has been any change to your symptoms, don't be afraid to go up to the triage nurse and let them know. Ask for a repeat of your vital signs, and then that triage score can be changed. I've seen that happen a lot, and it happens often, where as things evolve, the triage score may change from a 3 to a 2, which is like an increase in the kind of urgency of it. And so, also an important reminder that triage is about risk, not judgment. And so this number is, again, like, it has very concrete values that go into it that then spit out this number. And so it really has to do with trying our best to prioritize people based on how sick they are and how urgent things are.
Okay. That's super helpful. Let's talk a little bit about testing and referrals from the emergency room, because we know, like you said, Shaz, the emergency room is to focus on ruling out immediate danger or life-threatening illnesses or conditions.
Mm-hmm. And so when people do end up coming in, like once they get into the ER from the waiting room, you're going to see a nurse, then you're going to see a doctor. And the assessment is done by all of the members of the team. And so when I'm asking questions, I'm trying to kind of like gather pieces of information and put a story together in my mind about what are the life-threatening things that I need to rule out. And that's going to guide the tests that I'm going to do. So that's typically going to include things like blood work, maybe a urine test, some imaging like x-rays or a CT scan, depending on what the presentation is. And it may even involve specialist consultation in the ER that then can potentially lead to further outpatient investigations or admission, kind of depending on how severe things are.
Right. And so you're doing what those life-threatening conditions are and referring for those life-threatening pieces. Some tests are done as outpatient investigations. So I have had patients have the emergency room refer them for outpatient investigations, and then we follow up as family doctors over time.
Yeah, so a good example of that is some cardiac testing. So somebody who, we've seen that they don't have a heart attack or anything bad related to their heart in that moment, but they might be referred for an echocardiogram, which is like an ultrasound of the heart that then can be followed up either with a cardiologist as an outpatient, so like a specialist referral, or with their family doctor. A Holter monitor, which is like a 24-hour ECG that like follows your heart tracing for 24 hours. Again, that can be done as an outpatient and then can be followed up in the community by either a specialist or a family doctor. So those are there are a lot of tests that we do end up doing as an outpatient because the patient doesn't need immediate admission because of something life-threatening in that moment.
Okay, so let's talk about admission right now then, Shaz, really briefly. You refer people to specialist colleagues, and then they may choose to admit them depending on the severity of their condition.
That's exactly it. And so there are many conditions that may actually need admission to hospital when they're either too sick to go home or they need active treatment in the hospital. So some examples of that, like if somebody is having a heart attack or a stroke, they need to be admitted and have active treatment. If there's somebody with, a pneumonia and they're requiring oxygen, they need to be admitted because you can't have oxygen easily at home. Somebody who might have a severe infection that needs IV antibiotics and they're too sick to go home. That's another example. Someone who needs surgery, right? So if you have a broken bone, like a hip fracture, or someone who has appendicitis that needs surgery, these are all examples of things that are not safe to go home and would be admitted to hospital.
So once you're admitted, the care shifts to inpatient teams from the emergency doctor's responsibility, and they're stabilizing and treating the acute issue. And then once things stabilize, people are sent home. And that's a big piece of actually a gap in care, I find, as a family doctor, is sometimes there's this gap where I don't hear from the hospital sometimes of what happened. There can be a delay in getting that discharge summary and the discharge planning. And that can be really challenging sometimes, especially for those who don't have a family doctor.
Yeah, I mean, that's a really important point because hospital care is not meant to replace primary care, right? There's acute care that happens in the hospital, but then there still needs to be continuity after discharge. And like you said, that is often where those gaps appear. And I think understanding what follow-up is needed after discharge is really crucial. It's also, if you are someone who, like you or your family member has been admitted to hospital, it is very important and encouraged to ask questions before leaving the hospital so that you have a sense of what that after hospital journey should look like and is supposed to look like. So let's shift gears and talk about how to advocate for yourself or your family in the emergency department, because this is really a hot topic right now. And it is important to be able to have that ability to advocate for yourself or have a support person there with you. Advocacy is not meant to be confrontational. It's really meant to be informed, prepared, and supportive.
Yeah, and I think there's sometimes a fear around advocating for yourself, Shaz, that our patients worry about being labeled as difficult. And that's a very real consideration. I understand that because you want to get, these are the same people that you're getting care from. But it's your right as a patient to ask for support. It is your right as a patient to advocate for yourself or your loved one if something is not feeling right. So one of the most practical things that you can do when going to the emergency room, first off, is to go prepared when possible. So knowing what your medications are, if you're on a number of medications, like more than 3 or 4 medications, having a list in your bag with you at all times is helpful. Knowing what your medical conditions are, allergies, and then understanding what your key symptoms are and having sort of a good understanding what those symptoms are and how they started and how they've changed are really important because, again, what we do in medicine is detective work. What you're doing as an emerge doc, Shaz, is trying to quickly figure out what could be going on here. And also, if you have access to any recent test results or discharge summaries, take those with you. So keep a little file for yourself because that helps us understand your story, especially in a busy stretch system.
Yeah. And I think, as I mentioned before, it's also important to know when to get reassessed, right? So if you are sitting in the waiting room and things are changing, it is so, so important. Like, and to the point where I think triage nurses often rely on patients coming back up because when there's, 80 to 100 people in the waiting room, it's humanly impossible to be able to reassess all of them in a timely fashion. And so if things are changing either for yourself or the person that you're there supporting, please, please let the triage nurse know.
And the other big piece that I always recommend, if it's possible, if you have somebody, bring somebody with you. A support person can help you in those moments. We're really vulnerable. We're scared as patients, and it can be hard to remember everything. So having somebody else there with you to help remember details, ask questions, and advocate for you if you're feeling unwell, overwhelmed, or dismissed, this is really important. And one thing that we have to also mention here is that we recognize that equity issues exist in our healthcare system. There's Black, Indigenous, racialized, disabled patients, lower income patients are more likely to be dismissed and not taken seriously, which makes it even more critical to be able to advocate, which is hard to do alone. So having somebody with you can be really helpful. Shaz, what do you think, like when somebody comes into the emerge specifically, do you have advice for someone if they don't feel like they're being heard?
Yeah, I mean, if you're feeling dismissed, it's important and okay to pause the conversation and like restate your concern clearly. And I say this very much understanding that when you're worried and you're scared, it can be hard to do that. But saying things like, I'm worried because this feels different than before, or can you help me understand what you're ruling out? Or I'm worried because this is getting worse. did this at home and it's not working, and now my pain has changed in this way. And if something doesn't sit right, ask for clarification, ask for reassessments. These are all very reasonable. And if you're able to, like you said, Sheila, involving a support person to either speak on your behalf, listen, write things down, talk to another team member can really help move that conversation forward.
And again, we can't say this enough. Like, you have rights as patients. Needing help to navigate the healthcare system is not a personal failure. It's a systemic issue that because we are strained right now. And so it's a time where we really need to advocate for ourselves. And it's a reflection really of how complex, stretched, and imperfect the system has become. And that's why we're doing this work. This is why we have our podcast. This is why we speak up, because advocacy isn't about demanding more, but about you being demanding in any way. It's about helping the system see you clearly as a patient, to serve you and to be able to take care of you.
Yeah. And I mean that, like you said, Sheila, this is why we're doing what we're doing, but information is not a substitute for access. It can, of course, reduce harm when access is limited, and really a big reason that we have such passion for getting this information out to our audience.
Yeah, and we continue separate from doing this work, Chaz. I think you and I are both involved in trying to advocate for changes in the system to make sure that we're addressing these needs. We see these challenges, and it's not on our patients to make those changes. It's on the system, the government, and the people who make these decisions to change things. And our goal is not to normalize a broken system. It's really to help people stay as safe as possible within the system that exists.
Absolutely. Yeah. And like you said, I mean, like we are both very passionate about advocating for the system outside of these kind of public platforms that we have. And we're going to continue to do this work because we know that people deserve clarity, honesty, and care, even when the system is struggling to deliver it.
So thanks everyone for listening. Please continue sending us your questions, and we'll see you next time on the Doc Talk podcast.
Thank you for tuning in to the Doc Talk podcast today. A reminder that the Doc Talk is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your own healthcare provider for questions related to your personal health needs. And make sure to follow us on social media at the Doc Talk Pod, like and subscribe and review wherever you get your podcasts.